Look, thanks very much, everybody. This session is the final in the series of the Codeine rescheduling program that's funded by the Commonwealth. We've had, was it 3 or 4 webinars? Seemed like an awful lot at the time. 3, but they're still online. You can still access the resources of those, including the video and including the presentations. So they're still worth seeing, and what we've tried to do with the program since it started was have a look at the issues around the rescheduling of codeine, which is a national agenda. We then decided, because that could get boring if you heard it 4 times, let's have a look at what the real implications are for rural communities. And from our perspective, it was not only that, it was about how do you manage pain appropriately, what are the issues around drugs of addiction, and if you take it to its extension, how do you manage palliative care in the late stages of terminal illness? And let's face it, rural doctors do the whole gamut of these things, and we often manage it in isolation without resources. So what we've tried to do is set up a resource that's available for everyone to go online and have a look at the webinars, go through the presentations and the questions and issues that were raised during those webinars. And this is a tie-it-down event that we're putting on today at this conference to finish the program. This will also be online, I believe. Now, we've been lucky enough to secure Gavin Chin as our final speaker. Gavin's actually the Director of Rehabilitation and Chronic Pain Service at the Royal Darwin and Palmerston Hospitals. He's a rehab physician with a strong interest in pain medicine, and I like the concept that the Northern Territory has of pain medicine and rehabilitation, because what we tend to have is anaesthetists doing pain medicine, endocrinologists doing pain medicine, rheumatologists doing pain medicine and running clinics. And they tend to handle a part of it and then drop them back in our laps with all sorts of drugs that probably don't work out appropriately. And then we have the pharmaceutical services branch and the drugs and alcohol people whinging at us because the patients are on narcotics put on by the specialists in some of these pain clinics. And then we have to manage the fallout within our own communities. So it's great to see Gavin's perspective, which includes rehabilitation. And he's been in run the chronic pain service up here for the last 15 years, does outreach services to Catherine and Alice Springs, and he's an ardent educator of GPs and rural doctors in the Northern Territory. So I'd like to welcome and thank Gavin for coming along. Thanks very much, Gavin.
Thanks, Dennis, and thanks for the warm welcome. It's a bit warm outside, so luckily the air conditioning is working in here. This is the tropo season in Darwin, so the weather's building up to the wet season, and humidity is about 90%, so please keep yourself hydrated. And just a few warnings. In the NT we have some dangers. So we certainly have crocodiles, and plenty of them. We have sightings on the beaches and also have crocodiles which jump for the tourists. Box jellyfish, yes, they're out in the sea, so be careful if you want to go for a dip at the beach. And we have king browns, which are quite venomous as well. So just be careful when you're out there. And if you really want to get up and close with some of the locals, there are some crocodiles in Mitchell Street, and you can pay to sort of swim with them if you want. So hopefully you'll be able to take home a few pointers about how to manage chronic pain and when to use opiates, but there are some dangers. So, starting off with the definition, the International Association for the Study of Pain has kept this definition going for a number of years now, and So if you look at, it's an unpleasant sensory and emotional experience. So the important thing is to remember it is also an emotional experience. And that will become evident as I go through this talk. There may be actual damage or there may be potential tissue damage. And I think there isn't, the only way that you can tell your patient has pain is if they tell you they've got pain. So it's all subjective. And what we've now found with treating persistent pain is that you need to treat the whole person. And as Dennis mentioned, rehabilitation is a whole person specialty. So we look at the physical, the psychological, and also sort of social issues, and try and help people with their disability. And a lot of people with chronic pain develop a disability. So what happens, or why do people get pain? So we do have receptors in our periphery and in our tissue, nociceptors. And so they will tell us when something is touching our skin, when something warm or something hot is getting too close to our skin, and also if someone is hitting with a tendon hammer and causing a bit of discomfort. You can also have pain generated when nerves or the central nervous system is damaged. And I see a lot of people with neuropathic pain, be that from surgery, from an amputation, a spinal cord injury, stroke sufferers, and then you've got the post-surgical patient. So surgery is certainly a cause of nerve injury. And then there are the drugs that we prescribe. Some of the drugs, chemotherapy agents and other drugs can cause nerve injury, but a lot of causes are due to things like diabetes and toxins like alcohol and other things like cancer can also be associated with nerve injury. So what happens when pain is generated? Well, it then is enters into our sophisticated modulatory system where we have a perception and an experience of pain. And the things that can affect pain are things like mood, arousal, sleep, and so forth. So this diagram here just helps to try and conceptualize what I'm talking about, where the pain generator is somewhere in your hand. So something's causing the nociceptors in your hand to fire off, and they send down the pain fibers. There are actually 3 different fibers, and understanding what they conduct is also helpful in understanding why people develop the pins and needles or the burning sensation when they have nerve injury. It then enters into your spinal cord and synapses in the dorsal horn of your spinal cord. And previously we used to think, or scientists used to think, that the nervous system for pain was more a hardwired system where a message would be received in your hand and it would send it directly to your brain. But we now know that isn't true. And you might have heard of the gate controls theory, which challenged that model. And now what we understand is that the dorsal horn of the spinal cord actually has a lot of influence on pain signals. And in the dorsal horn, pain messages can be amplified, and it's thought that this is one of the reasons why people do end up with chronic pain. Sending down from your cortex, there are lots of descending pathways, and they can also influence your pain. So, for instance, if you're having a really shitty day and you've got pain, then that's not going to help you cope very well with your pain. And so there are these descending influences. If you're having a really good day and you've just won a lottery, then you might actually cope a lot better with your pain, and it may become less of a concern at the time. So once the dorsal horn has received the message, it then can be modified at that level before it gets sent up to your cortex, where that's where you perceive the sensation. So that sort of gives you an idea that the central nervous system can actually become sensitized to pain. And we now think that quite a number of the chronic pain conditions does lead to central sensitization. So this is another dimension where the nervous system has changed, gets distorted, or can amplify pain. It can increase its degree, duration, and spatial extent, and then no longer directly reflects the specific qualities of peripheral noxious stimuli, but rather the particular functional states of the circuits in the nervous system. So, in simple terms, it's an amplification of neural signaling within the nervous system that elicits pain hypersensitivity. So, sensitization of the nerves and nervous system has been well demonstrated at a receptor level and also a cellular level. People have possibly been sunburned at some point in their life, and have you thought about why your skin is so sensitive? Well, the reason why is that because your peripheral nerves have actually become very sensitized, and so even having a shower or wearing something that's a bit scratchy really is very uncomfortable. So it's just an example of nerves being sensitized. So the biopsychosocial model, which is what rehabilitation physicians tend to use a lot when approaching their patients, and it works quite well in looking at how pain affects people. So in medicine, we tend to focus a lot on the biological model. And we try and find tissue damage. We try and look at, is there any inflammation? What's possibly triggering the pain, and so forth. But your patients also have psychological issues, and they may have certain beliefs. They may have looked up on Dr. Google and found that their headache could be due to a brain tumour. So you need to be aware of some of those influences that people have at their sort of psychological level. They may have previously experienced pain in their childhood and have developed certain coping mechanisms. And then don't forget the social circumstances of their situation. They may have a work-related injury, and so we know that work-related injury does actually increase your chance of chronicity. Or there could be some other secondary gain to actually continuing to have be in the sick role. So I think the psychosocial component of persistent pain is certainly one of the greatest predictors of disability. So I think what you need to remember is that don't just try and focus on the pain, but you also need to look at how the pain is influencing the person. So what do we do with someone who comes to you with pain? So I think you certainly need to probably set aside a bit of time to try and work through these issues. And I know that it's not easy to get through an assessment of someone in chronic pain in sort of 10 to 15 minute consult. So you probably need to look at allocating a little bit more time to get through and get a thorough assessment. So it's important to not just take a medical history and do some medical examination, but also to do a reasonably good pain history. It's important to differentiate whether this problem is acute or chronic, and if you can, try and determine the possible mechanism. So in particular, is it something that is visceral, or is it something that is musculoskeletal? Is it from sort of neuropathic and all those sort of things? I think if it's gone on for more than 3 to 6 months, then it certainly will be defined as being chronic. And I think that's when you need to think about assessing the impact on their function, the psychological, cognitive and social status, which then will lead to this multimodal management of their pain. And medication is just one of the treatment options, and so hopefully you'll learn a bit more about when to utilise medication. So we need to sort of remember to not miss any red flags, and it's important to ask a few key questions and also examine the patient in trying to exclude the possibility of a red flag. But at the end of the day, red flags are actually very uncommon. So you do need to exclude, for instance, back pain, that there is very small chance or no chance of a fracture. It can depend on the age of your patient. So if someone is elderly and they've had a simple fall, then you may actually have a higher suspicion that they've had a fracture. And so you may actually want to try and confirm or exclude that. Certainly asking questions about other features that may suggest there's an infection. So fevers and weight loss and those sort of things are important to ask about. And if they've got a history of cancer, then I think you need to have a higher degree of suspicion that it's not something that's related to a tumour. And if they've got some other pre-morbid behaviours or they're on medication which sort of immunosuppresses them, then you also need to be a bit more suspicious that there may be some sort of infection. And then if you can do a fairly simple neurological examination, especially in their lower limbs for back pain, that will help you to eliminate or try and at least have a better idea that there's no acute neurological problem. And don't forget to ask about the bowel and bladder function. So I think multimodal is how you need to start thinking about managing these patients, and to remember that opioids are not the answer. I think when opioids were started to become more available in oral form, I think there was a lot of thought that these are the drugs that could actually help people with their pain. And so there's been quite a significant swing. The pendulum swung back the other way. Opioids were used a fair bit, certainly 10 to 15 years ago, and now we're sort of moving back the other way, and we're limiting when we prescribe opioids, because we've now become a lot wiser in how useful they are, especially in the longer term, and also become a lot more aware of the long-term side effects. So to try and help your patient develop a more multimodal approach to managing their pain, you do need to look at the physical, the psychological and the medical strategies. And I think getting your patient to understand that in most cases it's improbable that you'll be able to provide complete relief of their pain. So I tend not to use the term painkillers because they actually don't kill the pain. I think we're looking at pain relief. I think education of the patient is critical in order to achieve the goals and the expectations that the patient wants. And you also need to try and get an idea of what their actual expectations are, because if they don't achieve their expectations, then they'll become more disillusioned and frustrated, and they feel that you're not helping them. So one of the first steps in people moving forward with their chronic pain is actually acceptance that they have a condition which is chronic. And I commonly use an example that, we as doctors don't have a cure for a lot of diseases. And a good example is diabetes. And diabetes is something we can't cure, but we can try and manage. And it's really managed, if someone can manage their diabetes well, then there's less input from the doctor. So there's diet, there's exercise, there's actually understanding what their condition is, and that they need to actually sort of manage their condition. And there's no cure. So psychological approaches, I think we have learnt a lot about what psychological factors influence pain. And certainly mood will influence pain. And anxiety levels as well. So in the pain clinic that I run, we do a simple DASS, and that looks for depression, anxiety and stress. And they're quite useful screening tools to try and identify whether your patient has high levels of anxiety or depression. I think trying to work out whether the person's got good or bad coping strategies is important, and then to try and identify issues like catastrophizing. So as I said, many of your patients will Google their condition before they come and see you, and they will then say, well, have I got this? And you'll then need to try and work through in explaining to them, no, you don't have that condition. And so people with pain commonly catastrophize about their condition, and they are trying to find someone to make sure that they're not going to die from this condition. And educating the patient and their families is important, because sometimes the carers of these people tend to be a negative influence. Fear of pain. A lot of people develop a fear that their condition will get worse every time their pain increases. And so when they try and move and do some exercise, of course, they experience a bit more pain, and therefore they stop doing those things, and then you develop a secondary problem of deconditioning. So they become deconditioned, they may gain a considerable amount of weight, which then leads to problems like fatigue and lethargy and all those sort of things. And certainly weight gain is not directly correlated with pain, but it will increase their risk of other medical conditions. And so I think addressing weight gain is important from a more general health point of view. So I think educating your patient about chronic pain is vitally important. I spend a lot of time actually counselling patients, and so trying to correct some of their misconceptions. They might have seen previous specialists who said, well, there's nothing wrong with you, okay? There's nothing on the MRI that I can find that is causing your pain. So a simple example that I give to my patients is that, have you had a headache? And most people have had a headache in their life. And so there is no test that we have in medicine which will diagnose a headache. And so we have to accept that the person has a headache and we need to treat it. Okay, so reassure and offer support. try and be positive, but stress that pain and quality of life can be improved. I think they need to have realistic expectations about their treatment and their goals. Try and reduce their fear of movement so that they can actually recommence being more active. And so I think having functional goals or activity goals are actually probably more important than focusing on their pain. And I see this a lot in patients where you ask them about their pain and they say, yes, it's the same. But then you actually look at, once they've actually started re-engaging with exercise and starting to do things using pacing and things like that, they're actually doing a lot more, but their pain remains the same. So they're actually more active and better off, even though their pain hasn't changed. There are lots of resources out there, and there are some good resources online that can help people. All right, so what about these drugs? So I think, I think you need to develop a sensible approach to prescribing these drugs and what to prescribe. So there's been quite a number of recent sort of publications and in the media about painkillers now killing more Australians than heroin. Opioids and benzodiazepines being the most commonly misused drugs. Common prescription drugs behind a wave of Australian overdose deaths. And this is all true, and we need to then start to work out how we're going to address this quite a significant problem with regard to prescription opioids. And I think the codeine upscheduling is certainly one of the ways that has meant that patients people who have pain or chronic pain have now actually gone to see the right person or the appropriately skilled person to try and help them with their pain, rather than going just to different pharmacies and getting codeine-based products. And certainly in hospital, we do see those people who've taken copious amounts of paracetamol combinations and also the Nurofen combinations, and ended up with acute kidney injury in ICU and so forth. So I think it's made those people who've been self-managing their pain, force them to actually go and seek appropriate help. And so I think this is where it's important that you have a good way of assessing them and then trying to work out, is medication a good option for this person? So there are lots of drugs, and as I said, 15, 20 years ago, when opiates started to become more readily available, we had lots of morphine-based products, and then oxycodone came on, and then we've now sort of started using buprenorphine, and then we've got fentanyl. So we've got a lot of pure opiate medication out there. Certainly the codeine-based products sort of sat in this level, but tramadol also sits there as well. And these other drugs, the antidepressants and anticonvulsants, have developed more evidence in how you can use them to help people with chronic pain conditions. So in particular, neuropathic pain management or treatment is focused more on these drugs, the anticonvulsants and antidepressants, than opioids. And we are now recommending that for neuropathic pain, that opioids are second-line drugs rather than first-line drugs. So I think we're sort of shifting away from thinking that opioids are a good option for people with chronic pain and also especially neuropathic pain. The other concern about these drugs is the abuse potential, and I think certainly becoming more and more aware of people abusing some of these drugs, and certainly fentanyl's becoming a very popular drug these days. Sorry, it's pretty small print, but what I tried to demonstrate on this slide is that each state and territory has their own rules about, what you need to satisfy to be able to continue to prescribe opiates for your patients. So I think certainly if you follow this pathway, you need to check your state and territory authority requirements, and if so, then you need to sort of gain authority to continue to prescribe. In the Northern Territory, we have a different system to the rest of Australia, and we have a sort of a notification system, and then we have GPs have to actually send in a notification and that they're actually prescribing for those patients. Okay, and if you're unsure, then I think it's very appropriate for you to seek advice, either from specialists or colleagues about how to manage this patient who is either on opiates or you think they might be suitable for opiates. You have two different sort of authorities working in parallel. One is the PBS Authority. So all they require is if you need more than 2 weeks supply, then you need to contact them and get an authority script. They do actually ask you if it's going to be more than ongoing, if it's going to be an ongoing prescription, then you actually need to get another doctor to confirm that. So you don't necessarily need a specialist to do that, but you just need someone else, another doctor, to confirm that this is an appropriate script. But at the state and territory levels, there are different requirements. So, moving on to what we now know about opiates. And so, the Pennington Institute put out this report last year about the annual Australian overdoses, which looked at between 2001 to 2015, what was actually happening to deaths and the causes of sort of drug-related deaths. They looked at the ABS data, so looking at the 2001, there were 981 deaths due to accidental drug overdose. But in 2015, the figure has grown to about 1,500 deaths, and so that's certainly a big concern that the number of opiate deaths and deaths due to drugs have increased. Certainly opioids are one of the main causes, or one of the drugs that have been certainly related in these deaths, and fentanyl has become a drug which is also starting to show its head as well. And what they looked at is the difference between sort of regional and sort of metropolitan Australia. So I'll just take you through some of the figures. So men are at a higher risk. Middle-aged Australians between 30 and 59, not the younger group. Indigenous Australians also are high up there as well. Queensland and WA, I'm not sure whether some are from Queensland and WA, but you guys are at the top. And especially people on polypharmacy tend to be at greater risk. So this is, the black line is the overall drug-related deaths in Australia. From 2001, it's risen into 2015. And then the accidental drug-related deaths, which is defined that it's an accidental overdose, not an intentional overdose. That's also risen, so in comparison to road accidents, so the green line is the actual car accident deaths, which has actually been coming down, and car accidents themselves are becoming less frequent. But the red line is actually the drug accident deaths due to drug overdose, and it's actually almost more than double the car accident deaths. So that is a concern, and it's certainly happening in other Western countries where prescription drugs are now killing more people than cars. Which drugs are the most risk ones? The opiates are certainly the top of the list. And then the benzodiazepines are the second. And so if you actually combine these two drugs, that actually becomes an even more potent combination. Just trying to dissect out what opiates are more concern. Certainly the top line here is oxycodone, morphine and codeine. And if you look at heroin, is actually a lot less. Fentanyl and pethidine and tramadol, you can see, have actually started to escalate from 2010. So there's lots of concern about fentanyl because it's a very potent drug, and it can certainly stop your breathing quite quickly. Now, what age group is a greater risk? So this red line is actually the age group between 30 and 59. And so you can see that the other age groups, less than 30, blue, and greater than 60, they've all tended to remain reasonably flat in their the incidence. But it's the age group that's been probably on the longer and on longer-term opiates than the other groups. They probably are starting to accumulate some other comorbidities like sleep apnea, respiratory problems, COPD, cardiovascular disease. And so when you combine that with long-term use of opiates, I think they're now starting to recognise that their risk of dying is actually becoming more and more significant. So a lot of people in that age group are what I call the sort of legacy patients, where they were started on these drugs about 15, 20 years ago, and now they're getting in the older age group. And as I say, when you combine them with benzodiazepines, it certainly increases their risk of sudden death quite a lot. These are prescription. Yep. So these are the deaths that we can try and do something about. This is just a breakdown of the different states and territories, and as I said, Queensland and WA are the top ranked, and I think Victoria's pretty high up there as well. When you look at regional Australia, certainly there's a greater increase in deaths in the regional Australia compared to metropolitan. And moving on to over-the-counter codeine. So as people know, from February this year, they became prescription only. And so codeine hasn't been shown to be that effective, especially in long-term use. And people do develop tolerance and physical dependence, and then they can go on to misusing the codeine products. Combined, as I said, with paracetamol and ibuprofen, if you take handfuls of these drugs, then you're going to cause some side effects from these drugs, which are reasonably safe on their own. And coming into line with the rest of the countries, in the US, most of Europe, Hong Kong, Japan and other countries, they're not available over the counter. So we're coming into line with those countries. And so those who are at risk are those who are unmanaged, poorly in chronic pain, and they are at risk of misuse and accidental overdose. The number of codeine-related deaths has doubled between 2000 and 2009, and certainly the accidental overdose has also increased. And certainly they've been sort of fairly high on the drugs that are misused in surveys that they've done. So I think to try and help reduce the deaths related to codeine-based products, we do need to try and educate the general population that codeine is not a good drug to just continue to take day after day and month after month. And I think we need to try and arm the pharmacists and GPs about what is a good way to manage their pain. And so if someone comes to you and they are asking for a Pennington Fort prescription, I think you need to sort of go through these simple steps. I think you do need to assess their risk of substance abuse, look at their medical comorbidities, look at what other drugs they're taking, whether they've got any mental illness. Calculate as best you can the sort of total daily dose of codeine. If it's less than 300 milligrams, then you could, and they don't have any other comorbidities, you could look at trying to withdraw the codeine fairly abruptly. But you need to sort of warn them that they may actually go through some withdrawals. But if you plan to continue on the codeine but actually try and wean them off because you've educated them about the long-term effects of codeine, that you do it at about 10 to 25% reduction per week. Do not convert the patients to other opiates. As I said, the other opiates also have their dangers as well. And if necessary, if they're over the 300 milligrams or they've got some other comorbidities, then seeking specialist advice. And certainly alcohol and other drugs have put out guidelines about how to manage codeine dependency, which is, this is the Northern Territory version. And there are these other drugs here that you can use to try and minimise their withdrawal effects. So their diarrhoea, their joint pain, their stomach cramps and sort of nausea and vomiting, those sort of things can be treated with non-opioid drugs. So just to finish off, I've got a couple of case studies, and I'll certainly appreciate a bit of audience participation. So this is a pretty common presentation, sort of a fairly young person, fell from a ladder. They appeared to have a soft tissue injury to their shoulder and back. There isn't any other serious injury. How would you manage that patient? Got a roving mic down here. Well, he's finding it difficult to walk, you know, get out of bed. That's why he's come to the GP. Certainly can't go to work because he's hurt his neck and his shoulder and his back. And so yeah, so hopefully, you know, he's a fairly capable 47-year-old. He was sort of climbing up a ladder, probably trying to fix his gutters or something like that. So he was physically capable before that, no other comorbidities. So he's a person who presents with sort of a soft tissue injury. Yeah, simple analgesia. I think that's the first thing. Say, look, you know, you've done some soft tissue injury to your shoulder and your back. It will be sore for probably a few days, maybe up to 1 or 2 weeks. But if you look, you know, if we give you some simple analgesia to treat the pain, it should improve. And, you know, if it doesn't improve, then come back and see me, and then we can look at if any investigations are necessary, or if they may need to be sort of treated with other modalities, such as maybe some physiotherapy and things like that. Give him some common sense advice. He shouldn't try and do a lot of physical stuff with his shoulder and his back. He may want to use some ice or heat, depending on the time frame from when he had done the injury, and just give him some generally good advice on how to help himself to recover from this acute injury. And I think that if you just use a simple analgesia, usually it should get better. But as I said, you might want to consider something else. Physiotherapy is an option. And if you really think it's necessary, then a very short course of something that's a bit stronger. You could consider, tramadol or even a codeine-based product, but then you need to look at following that patient up to make sure that things have improved.
If you are to use a codeine-based product, like you said, do you have a preference of using more of a regular sort of oxycodone regime versus something like your long-acting naloxones?
Well, I think, as I said, oxycodone, that's definitely an S8. Codeine-based products and tramadol are still S4s. So if you want to sort of use that as an indication that, one endone sort of oxycodone is actually a much stronger drug, and it is. It's a pure opioid, so it has all the risks of opioid side effects, and certainly oxycodone can be abused. It's less likely if you give them a small amount of codeine, or if you give them, a limited amount of tramadol. I would tend not to try and use oxycodone if it was at all possible. I'd probably stay away from morphine and fentanyl and all those other sort of more potent opiates. And so I think tramadol and sort of codeine-based products for a brief period of time would probably be a better option, and make sure you actually review the patient so that hopefully things are going to get better.
Just
Yep.
Would the non-steroidals be more efficacious than paracetamol?
Yeah, probably. Yeah. And, there's a lot of non-steroidals out there. You can still buy sort of Nurofen over the counter. So a lot of people have tried Panadol or Nurofen already, but sometimes some people haven't tried it. And so I think just giving them some simple analgesia is the first step. You can think about a long-acting non-steroidal or a non-steroidal that has less GI side effects if some people sort of stop taking it because they've got the reflux and all those sort of things. So maybe think about a sort of a COX-2 inhibitor like Celebrex or meloxicam.
There was an article in the British Medical Journal that showed that topical non-steroidals like Voltaren or diclofenac gel 3 times a day with heat plus simple analgesics like paracetamol was as effective as opiates. I've tried that, and I can't say honestly that it's actually been as effective. It's nice to have something to back your argument up to the patients, but after a while I don't believe you.
Yeah, I mean, I think, anti-inflammatories, we know that they've been around for a long time, and we hopefully have become a bit wiser in when we use them, and we need to be more careful if people have pre-existing GI problems and renal problems. But for brief periods, they can be quite useful. They certainly aren't, the same analgesic. They don't give the same analgesic effect as opiates. You know, if you've had an operation and you have quite a lot of acute pain, then we will give you opiates because we know they work. So I think opiates, you know, have their role, but we also need to understand the pitfalls of ongoing prescription of opiates. And I think that's the sort of key, is that once a condition has finished becoming acute and then becomes chronic, then the opiates are certainly not the drug of choice for long-term chronic pain.
The other issue that has concerned me, I have a lot of patients with chronic disease, diabetes, chronic renal failure, you know, stage 3B and 4. And these people have frequently got severe pain, osteoarthritic pain.
Yep.
Non-steroidals are frequently inappropriate, and I have
Totally
great
agree.
difficulty managing them. The tendency from the pain management people in our area tends to be buprenorphine patch, or, you know, one of the patches. If their renal failure is really bad, that fentanyl seems to be the option that most of the pain management people.
Yep.
Are there any other things that you find you can use in that situation? And the second question, there's reports now of pregabalin and those agents being addictive in an equally effective manner as the opiates. Do you want to comment on those for us? Thanks, Gavin.
Yeah, so the second case is a much older person, and you know, they've had ongoing back pain, and they've got sort of becoming more sedentary and less active, and their weight's sort of going up and up. They've also got a pre-morbid history of heart disease and sleep apnea, and they may have renal failure as well. And so, you know, they come and to you and say, look, I've been previously taking the 8-Panadine Fort, but it's not enough. What do I do? And so I think this is sort of a very common presentation to pain clinics, because the GPs are asking, you know, what is appropriate for this type of patient? You know, they're not someone who's potentially going to be abusing the drug, but they've got a lot of other medical issues that we're sort of concerned about their use of opiates. So I think, again, I would go back to sort of the multimodal approach to managing this patient and look at, you know, what things are influencing their lower back pain. I mean, they may not actually doing the right thing, and, you know, he may continually be sort of bending over to using his back and not using his legs and thighs, which are the bigger muscles. He's certainly not doing enough because his weight is going up, and you need to try and address that because it's something that's certainly going to be influencing his sleep apnea, and also you know, a risk factor for more cardiac disease. So I think as sort of primary care physicians, it's important to point out that, look, you are overweight and you actually need to do something about it, because it's going to cause more and more health problems. And, you know, that if he loses some weight, then that's less weight that his spine is actually going to be having to move around every day. So, yes, there is an option of probably using a buprenorphine patch in this person. But I think the plan would be to not just put him on the patch and not do anything about all the other things. I think it needs to be, you know, the whole person approach, and say, look, you know, you need to start to make some changes in your life and take more responsibility for managing your back, because it's probably not going to get better as if you continue the way you are, but if you start doing more activity and trying to look after your back, it's certainly going to help. Use the buprenorphine patch for hopefully a limited period of time until he actually gets active. Think about him being seen by a physiotherapist and using the sort of Medicare-funded sessions to sort of kickstart him into start doing the right things. if you can sort of try and find a physio that is actually someone who's not just going to do hands-on treatment, but is actually going to focus more on exercise and activity and actually things which are going to sort of help manage his back problem rather than just passive treatments. And so trying to avoid sort of passive treatment, like just taking more tablets or just going for a massage. I think, you may need to delve a bit deeper into his depression and, as he's getting older, he's losing more independence and he's not getting out as much and he's losing his social contacts and all those sort of things, or his, relationship with his wife is not as good as it used to be and it's sort of making him more depressed. So treating the depression is certainly going to be one of the things that I would suggest. And so I think you would have a multimodal list of treatments. One would be to educate him about his back and how he can try and manage his back a lot better. Try and address some of the underlying problem factors which are adding to his pain, such as his being overweight and having very poor exercise tolerance. Try and improve his mood. He may have problems with sleep as well. I mean, hopefully he's using the CPAP if he's been treating that properly. And if necessary, introduce some buprenorphine to try and break that pain cycle so that he can actually start to become more active. And, I think at the end of the day, opioids are sort of not the answer for this patient. Yes, you may need to use them for a set period of time, but you need to try and set these other goals and not just focus on prescription medication to help with his pain, as in prescription medications, which are the only option, treatment option. So try and develop a multimodal approach. Well, yes, it may be he may be a patient who's got, certainly I've got people who've got a bad hip. They're not suitable for surgery because they've got all these comorbidities. He may be one of those people where, he may need to be on a sort of a small amount of opiates. And certainly the actual doses of opiates that we have been using has actually been sort of brought right down to, people are starting to talk about, say, 40 milligrams of sort of oral morphine equivalents. 1 or 2 years ago was more like 80 to 100 oral morphine equivalents. So certainly large doses of opiates is certainly seen as the, can affect, alertness, affect people's ability to drive, increasing their risk of the side effects and sort of sudden death. So small dose of buprenorphine may be the answer for this man in the longer term. But Yep. Exactly. Yep. I mean, a lot of people try and exercise, but what they do is they think when they were in their 20s and 30s, they try and go out and, run around the oval a few times. and they say, well, exercise doesn't help. But if you've got an exercise physiologist who actually can, coach them in that process of gradually reintroducing exercise, there's lots of benefits in exercise. I mean, there's, it's been promoted for even as you get older, you need to continue to exercise. It helps other conditions, diabetes and heart disease and respiratory disease. So there's lots of benefits in exercise, and we should be promoting more of it.
Hi, Gavin. Just wondering if you have any tips on how you approach these two cases differently if they're Indigenous people living in a remote setting, no access to physio, and maybe different sort of setting.
As mentioned in the beginning, I do go down to Alice Springs and Catherine, and you know, as you get further out from the metropolitan centre, services drop away quite a lot. So yes, you can't see a physio, you can't see a psychologist, let alone see a specialist who can sort of advise. So what I do when I see an Indigenous person is I do my best to try and, you know, explain to them that, you know, you've got a condition which we're not going to be able to fix it, and the medication can provide some benefit, but you do need to try and change some of the lifestyles. And you know, I think it's, you know, I think this conference is sort of talking about how we are or aren't closing the gap. But I think a lot of, you know, health issues in Indigenous communities are more to do with lifestyle. You know, are they eating the right types of food? Are they doing the staying away from some of the things that are you know, causes of health problems like alcohol and cigarette smoking? So it's certainly very tough to try and implement multimodal approaches to Indigenous people, and plus you've got the cultural and the language barriers. I think trying to provide good advice to the DMO or the GP that's treating them about the medication point of view, but as I said, I try and counsel the patient about lifestyle. I know it's certainly, it's hard to sometimes see that there's going to be any change, but I think you've got to provide sound advice rather than say, well, just put you on opiates and it should help you. And you know, I think that's sort of putting them down the wrong path. So,
I just have a little question to you regarding pain management. Now, we find out that a lot of time patients present to the GP with, you know, persistent pain. Now, eventually, they may have gone for surgery and had a laminectomy or discectomy done, and then the surgeon has put them on lots of opioid, you know, to help improve the pain, and then put them on lots of medication as much as they wanted.
yeah.
Now, they come back to the GP, and then, you know, of course, they're not going to get better, and they continue to have persistent pain, and then the GP has referred them to a specialist. Yeah. And then after review, you get a long letter from a specialist detailing all the stories, and then tells you, could you try this patient on in-depth 5 milligram, you know, Nocte, and then see how he goes, and then I'll review this patient in 4 weeks' time. Yeah. Now, you know, and then he makes recommendation, try to reduce the opioid dose. And then the GP gets into trouble here with this patient because he's benefiting from these lots of opioid, and GP is going to say to him, you know, you got to go off this opioid. It's not good for you. It doesn't help you in neuropathic pain. And then he's got a letter from the specialist, which he just only says, try him on endone. And then the GP gets stuck. Now, is there a national framework that, you know, the pain faculty sort of putting up to sort of help, you know, close that deficit? Because you find out that the residual problems that the GP struggle with some of the time are also started by the treating surgeons, and then not having also access to pain specialists to sort of give, you know, ongoing management. Because if you were sort of managing this patient ongoing, they would sort of maybe understand better because of your better and expert knowledge of them than the GP would. So what would you like to say about all that?
Yeah, so I think your sort of example highlights the thing with our health system. You know, our hospitals are sort of pushing out people as quickly as they can, and so a lot of our patients that are being discharged on sort of, you know, opiates because they're trying to get people moving and out the door. I think that surgeons and in particular anaesthetists who actually manage these post-operative patients do need to actually follow them up with regard to their pain. And there has been a sort of a statement put out by the Faculty of Pain that people shouldn't be discharged on slow-release opiates post-operatively, and they should just be sent home with endone. I think that's probably not a good way to go, and I think that it's more about following the patient up and actually trying to help them get through that post-operative phase and eventually get off the opiates. So I certainly see that GPs tend to land with these patients, and they sort of try and work out what they should do, and should they continue the opiates or should they wean them off. And I think in most cases people would be advising GPs to actually try and wean them off. And if they do have neuropathic pain or they've got sleep disturbance, then I think the tricyclic would be a good option. So if you had a back surgery and there's residual sort of neuropathic pain, then the tricyclic may be a good option. I still think that applying the multimodal approach to your patient, yes, he's had back surgery, but he does need to try and gradually get back to being active. Most surgeons will give instructions to the patient, but some surgeons don't really give much instruction. So I think, referring them to, they should actually have a follow-up with a physio at least, and be advised on what things they should gradually try and do over the next 3 to 6 months. So I think my advice would be that in the post-operative patient who comes to your practice, that really you should be trying to wean them off the opiates for their post-operative pain. If you have difficulty weaning them off, then I think you should then get them back to the specialist or to the pain clinic and try and get their input. But I think you still need to apply that multimodal approach to that person, even though they've just had surgery. Because sometimes these people end up still having pain despite having surgery. Yeah, so you're talking about Brain Man? Yeah. Yep. Yep. It's an international phenomenon.
I'd like to thank Gavin. That was right on the money. Thank you very much, Gavin. We appreciate your time and effort in coming here for this, and putting the end brackets on the codeine rescheduling program that ACRRM's been running. So again, thank you very much, and I'd like everybody to express their gratitude. Yeah, thanks, man. Appreciate it.